Dear Felix, dear Wolfgang, dear Stanislav, dear Lothar especially, I skipped, as you see, from Berlin to Munich, as you know, probably from Peter already, and I cared for the patients in our department as the senior house officer in the outpatient care department, and I cared for pregnant women with congenital heart disease. And my topic today is about talking about pregnancy in good patients with left heart under pressure. And as we heard the last 2 days, it's the aortic stenosis and the coarctation. The mitral valve stenosis I will skip on. It's not normally congenital theme. And the hypertrophic obstructive cardiomyopathy. And my speech will be based on the ESC guidelines, which gives, from my opinion, a very good guideline how to deal with this patient group. Just to bring you in this topic of Wolfgang as an obstetrician, because we normally don't think about what happens during pregnancy, I will I have to use this, give a short introduction. What is the problem in our patient group when they want to get pregnant or when they come already pregnant to our outpatient care department? As you see here on this graph, we have, starting with the gestation, a huge increase in the mid of pregnancy of blood volume, especially plasma volume, and also of cardiac output, which is, I have to use this, I'm so agitated, in the mid-pregnancy, where we nearly reach 40% more cardiac output. And this we have it in a patient group with a left heart under pressure. And on the other hand, we have a heart increase and a reduction of afterload. And when we start of thinking of aortic stenosis, most of the patients suffer from bicuspid aortic stenosis, and we keep this in mind. We have to counsel these patients if it works or if it doesn't work. And of course, it depends on how the patients are corrected, or if they aren't corrected, or how they come to our outpatient care department, if we counsel them to go on with pregnancy, or what shall they do. We have to keep in mind that we also, when we talk about aortic stenosis, we talk about this dilation of the ascending aorta. And just to tell what's normal in adult patients, we have to look at the aortic valve area. That's only to give an overview. This is concerned on the guidelines, how they defined, for example, critical stenosis, and what we normally measure. Normally, we measure the gradient. And is it a good tool to measure the gradient? We have to ask us this question. And a pregnant woman, probably, we have 2 conditions we have to think of. One condition is probably we overestimate this gradient because of the increased cardiac output. And on the other hand, do we have still a bad left ventricular function which leads to a lesser gradient? So in my opinion, it's better to try to measure the area of the aortic valve. What happens, I already told you. We have a preload increase, which is in the maximum of the 20th to 24th week of gestation, and which leads to an LV overload, which might lead to congestive heart failure and severe pulmonary edema. And on the other hand, we have in the 3rd trimester maximum a heart rate increase, which decreases probably the coronary perfusion and might lead to subendocardial ischemia. And this leads to complication, and it depends on the gradient, of course, or on the valve area on the maternal side, like to pulmonary edema, to heart failure, angina, syncope, sudden death, arrhythmias, endocarditis, or probably also to a dissection risk if we have a dilated aorta ascendens. And on the fetal side, we probably have to deal with problems like abortion, premature labor, or too small infants because they have a decreased uterine perfusion. And how is the course about these patients? Normally, if we see women with mild to moderate stenosis, we have an uncomplicated course, and the patient remains symptomatic, asymptomatic. But we have to look after the aorta ascendens if they come in a pre-pregnant situation, and look how is the diameter, because there are clearly good guidelines concerning the diameter of the aorta ascendens and the pregnancy. If it's more than 50, try to encourage the patient to do first surgery and then to get pregnant. If it's severe, and that's concerning the guidelines, and you find early signs of heart failure, you should start with diuretics. And just be aware that the problems start in this patient group in the mid of pregnancy. If you have tachycardia, you should start to think over beta blockades, even if the patient is a little bit confused and they say, but it's not allowed. Normally, it's no problem for the patients. And you should concern about balloon valvuloplasty only as a rescue therapy. And the valve, if you have to make a balloon valvuloplasty, you have to find a valve which is non-calcified and has minimal regurgitation. And try to avoid surgery because they have a high mortality, not only for the mother, but especially for the fetus. And if you make counseling, just think over if you find a symptomatic patient with severe aortic stenosis or an asymptomatic patient with impaired LV function or pathological exercise. I think Dr. Hager will tell us something about that, and we heard already from Dr. Peters about that. You should, these patients, give a counsel to say, first of all, try to improve the aortic stenosis and afterwards become pregnant. And on the other hand, pregnancy should not be discouraged in these patient groups if the patients are asymptomatic. That means the LV size and function and exercise tests are normal, even you have a severe aortic stenosis. What about the delivery? That's an important question. We normally come into contact with the obstetricians because they ask us, how should the patient go for the labor? And you can normally say, as a general rule, and depends on the special patient, how she wants to become delivered from her baby. If the patient has got, from the cardiological point of view, a severe aortic stenosis with symptoms, it's much more controlled to do a C-section. But you can tell the ladies, if they don't have any problems, they may do it also spontaneous. You should avoid vasodilative drugs, and you should not give any fentanyl bolus and no test doses of epinephrine, which might lead to an increase of the heart rate. And I can't tell you anything about pregnancy in this patient group without telling you that the information concerning the counseling before pregnancy is if you have a woman with severe aortic stenosis, she will ask you, what shall I do? Which kind of valve should I prefer? There's still a discussion, and you have to talk about the modalities, how to replace the valve, probably by the Ross procedure, or probably by bioprothesis, or by mechanical valve. And then we can only tell the ladies that we don't have a lot of experience concerning the Ross procedure, but we can tell them something about the anticoagulation and which form of anticoagulation is most recommended for the patients in mechanical valves, and how do they want to what kind of valve replacement they want to have. And if you try to give any information concerning the anticoagulation regimen and the decision what kind of valve replacement they will have. You have to think in two special directions. One direction is the maternal point of view, which looks after the maternal complications in different anticoagulation systems. And there's a work from, it's nearly 5 years old, from one group who looked after the complications in this patient with different anticoagulation regimen. And as you see here, if you look after the thromboembolic complications, you have got most complications with the use of unfractionated heparin through the total pregnancy, and nearly 10% when you use it in the first term of pregnancy, and the lowest rate of complications when you use Macumar, for example, or warfarin. That's the side, the point of view of the mother. And then you have to look at the fetal complications. You might indicate when the pregnant woman take only heparin or heparin during the first term or anticoagulation with Macumar. And as you see here, the risk of embryopathy is most in these groups who are taking the whole pregnancy Macumar. But this changed a little due to other studies who looked especially after the dose of Macumar you take. There were studies in the end of studies from Vitali from 1999 who clearly defined, and there were following studies who confirmed these results, that if you have got, and that's the main information, Macumar doses of less than 3 milligram, you should continue taking this. And if you have doses where you have to take more than 3 milligram, you have a really higher risk of getting an embryopathy. And we're talking about, in comparison of lower, that's about 2.6%. And if you, of lower doses, when you have less than 3 milligram, yeah, that's about 2.6% of the risk of embryopathy. And when you have higher doses, it's about 8%. Yeah, and then you have to remind that some patients are coming after the third trimester, so you don't have to go on with this discussion. But you have to make clear information to the patient that there are risks, and then they can decide what kind of valve or what kind of regimen they would like to have. And if you are more interested, they give really good ideas how to deal with the target of anti-10A factor levels. But it's written here, but there are still discussions which are going on. What's the right time of checking these levels, and how often do they have to check this? And it's very interesting because, on the other hand, these are recommendations by the ESC, yeah. But on the other hand, for example, low molecular weight heparins are not labeled for patients for mechanical valves, for example. So it's a discrepancy, and it's still under discussion. But you have to make very clear to the patient that there are risks if they take oral anticoagulation, and on the other hand, there are more risks for the women, for example, if they have mechanical valves, for thrombotic complications. So now I swift to coarctation, and as we already heard, the main problem in coarctation we have to deal with is arterial hypertension and this systemic disease of arthropathy. And if we care for pregnancy in these women, we have to talk about the risk of getting aortic dissection, of the risk of getting aortic rupture due to the changes of the estrogen levels in the pregnancy. I think it's not very well known that these patients have also risk of rupture of cerebral aneurysms, which are not diagnosed before, and they have the risk of LV failure and endocarditis. And on the fetal side, there are, like the aortic stenosis, risk of reduced uterine blood flow, in elevated offspring mortality, preterm delivery, too small babies, and in this patient group, prenatal placental separation. And if you look to the studies concerning the coarctation, there are a lot of studies which look after a few pregnant women with coarctation. The main problem was hypertension, and this was described in a range from 10% to 50%, and you can find everything. But in my special experience, when I was working and looking after these patients, it was a little bit less, but about 10 to 20% of hypertension when the patient had a rest gradient. What's the most important thing, if you have this patient group, talk about pregnancy before they become pregnant, because, and that's very important, they often have ACE inhibitors, and they are teratogenic in the pregnancy, and you should tell the ladies, just when they don't want to become pregnant, if you want to become pregnant, then change it to another drug to deal with your hypertension, because it's they don't feel comfortable with this when they are pregnant, and when they have ECE inhibitors and they become pregnant and they didn't know that, yeah, before. And check also for the associated diseases like bicuspid aortic valve, which are often in these coarctation patients. And if you plan the delivery, it's normally recommended to allow them to make a spontaneous delivery. But if they don't feel comfortable, I think it's also okay to tell them that they do a C-section. I think it's not only a decision by the cardiologist, it's also a decision how the lady feels more comfortable with. And as a take-home message, or as a rule, you could say that a residual graded below 20 millimeters of mercury normally is associated with an uneventful pregnancy. Now I swip to the next. It's the mitral stenosis, and the mitral stenosis, it's normally not so congenital, and these are the points we look. Normally, they are classified in the ECE guidelines also after the mitral valve area, the peak gradient, and the pressure half time, and they are classified as mild to moderate if they are like this, and to severe if you find less than 1 square centimeter, more than 12 millimeters of mercury, and if you measure pressure half time of more than 220. And they are normally of rheumatic origin, and we find these patients too because we have a lot of migration, and we have people from all over the world, and the congenital mitral stenosis is of less importance in our population, and we have to look these mitral stenosis like patients with acquired disease. And the complications they have, of course, it's always a little bit the same. They have heart failure, and this is special because they often have atrial fibrillation, and we have to deal with these atrial fibrillation very aggressive in the treatment, because if they have atrial fibrillation, they have a high risk of thrombus formation, and this leads to more aggressive therapy, and we have to give therapeutic anticoagulation if they have this, that they might get pulmonary edema, endocarditis, of course. If they have the mitral stenosis of rheumatic origin, you have to go on with the prophylaxis of penicillin, for example. We see pulmonary venous hypertension with consecutive RV failure. We see small babies, and like in the all left heart obstruction, we have a compromised uterine blood flow, and we see too early and too small babies. And we see it often. And this was 12 years ago. And then I looked into the really new data, which were from the registry of the ESC group. And these were about 1,300 women. Most of them had congenital, but also valvular heart disease like mitral stenosis or regurgitation, and they were from the last 4 years. And I looked after the mortality, and I was very impressed. They only had 1% over all pregnancies of mortality, but they have 1/3 mortality of mitral valve stenosis. So you can see in Europe, mitral valve stenosis, even if it's low, it's only 13 patients, it's still a problem which is not clearly managed by these centers which participated, and these were big centers with great experience in patients with congenital heart disease and women. How to treat these patients when you get problems? If you have symptoms and if you have pressure bigger than 50 millimeters of mercury, start cardioselective beta blockade, and if the symptoms persist, introduce diuretics. If you have paroxysmal or permanent atrial fibrillation, you have the risk or already LA thrombosis or prior embolism. These patients should have therapeutic anticoagulation, and it's absolutely needed that you control this anticoagulation. And you have to think of that you have to adopt this anticoagulation because during the pregnancy there's a higher plasma volume, as I told you, and you can't start with a low doses and don't do a control. You have to do it because during the pregnancy the volume increases and you need higher levels, and you have to adopt these levels to these anti-10A levels, and you see that in reality sometimes you have to double the dose. Anticoagulation is reasonable also in this kind of situation when you have moderate or severe mitral stenosis with a spontaneous LA echo contrast, or of course if you have impaired LV function or you have an enlarged LA size. And what's also very important is the heart rate control. If they get in a high heart rate or they get if they get tachycard, you have to start with beta blockers because patients get very quickly symptomatic. And if this doesn't work, you have to think if a balloon valvuloplasty is necessary, and the criteria for doing a balloon valvuloplasty in these patients are that you have a valve area of less than 1 square centimeters, and you have impaired function, New York Heart Association function, and you have to check if the patient have got mitral regurgitation, or if this doesn't work, you have to concern about surgery, not to bring the patient into problems. And if you have to think of surgery, you should think of surgery when patients are below the 20th week of gestation to try to keep the fetus alive, because that's the most problem in the surgery with the cardiopulmonary bypass is the fetal mortality. If you make counseling concerning labor, you might counsel to in mild stenosis patients or moderate with not so impaired New York Heart Associated functional class of 1 or 2 without pulmonary hypertension of spontaneous, and this is the opposite if they are severely impaired with impaired New York Heart Associated function or pulmonary arterial hypertension. I think there's no discussion about cesarean section because it's more safe and you can control it. You can introduce an PA catheter for fluid control, because on this side during the labor patients lose fluid, and it's very important to check this fluid control and to do this in a center where you might also bring the patient to quick surgery. Now, the last point is the hypertrophic obstructive cardiomyopathy. It's nearly the same as I told you for the aortic stenosis. We have an increased risk when we have high LVOT gradients and symptoms, like in aortic stenosis. Try to induce beta blockades when you have a wall thickness over 15 and control the heart rate and introduce antiarrhythmia therapy early, and try to bring the patients probably to therapeutic anticoagulation when you have got intermediate problems of atrial fibrillation. Even if you have got this, you try to think of a cardioversion due to the pregnancy. Normally, pregnant women tolerate this, and they feel they get asymptomatics when they are heart controlled. And the management in this patient group is similar to aortic stenosis. And my last, just before last, this is a work from the Netherlands group. They looked after risk factors for cardiac complications only in good patients. The other well-known risk stratification factors is by Zio and co-workers. They also looked after patients with acquired heart disease. They looked only after good patients, and as you see, as I pointed out, that the left ventricular heart obstruction, so the left heart under pressure with a gradient, peak gradient of more than 50, or an aortic valve area below 1, is per se a risk factor of 2.5. And most of the patients have a history of arrhythmia, they have cardiac medication. So if you look after these points, you have 3 and plus 2.5, so you have over 5. They are in the range of more than 3.5, so you see more than 50%, so 70% suffer from cardiac complications. So I think it's shocking because when you talk about pregnancy in this woman, most of the patients are in between this, but you have to tell what the risk factors are, and you have to decide if you bring these patients in situation of better pregnancy, cardiac situation to become pregnant and not to fall under this risk group, and then they can deal with this pregnancy in a better manner. And now, that's my last slide. If you take now all the left heart anomalies, and you try to make a risk stratification, and you try to find out what did I learn from her talk, you can see where are the patients with a low risk when they have pregnancy. Of course, these are the patients with no residual problems, or the patient with a bicuspid valve. Why with a bicuspid valve? Because they have these enlargement of the aorta ascendens in sometimes, or you have a coarctation which is native with a low gradient, or a mild to moderate mitral stenosis, or a mechanical valve, or a mild to moderate aortic stenosis. They have a moderate risk. These patients should be cared in a good center for pregnancy, together with the obstetricians which care together, because at the end of pregnancy, the obstetrical problems also become a problem. And we have, especially in the group of coarctation patients, we have to think over if they have hypertension due to preeclampsia, for example, or from hypertension due to their heart defect, and you have to decide which kind of delivery they will take. So these patients are necessarily under good control when they are in a center where you have a close cooperation with the obstetricians. So, and the severe, of course, I don't forget, these are the, you don't encourage these patients. They have to go for correction before they get pregnant, but in some cases they are in your outpatient ambulance and they are already pregnant. So you have to try to find a way to bring them over the pregnancy without severe impairment for the baby and the mother. Thank you very much.